Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lizzie Smith-Rogers. More and more patients are leaving the pharmacy without the medication their doctor prescribed because of insurance barriers. Stephanie Desmon talks to health economist Joe Levy from the Johns Hopkins Bloomberg School of Public Health about his new study that looks at just how often that happens and what it could mean for patients. Let's listen. Joe Levy, thanks so much for joining me.
Thank you, Stephanie. It's great to be here.
Most of us have either experienced this ourselves or know someone who has. You leave your doctor's office with a prescription, head to the pharmacy, and you're told your insurance will not cover it. Your new study asks just how often that's happening. What did you find?
That's exactly what we were studying. And what we found is that happens quite a lot. If you look at all of the numbers that we have, it happens about 32% of the time when a patient has gotten a new prescription from their doctor for a medicine they've never had before. It gets sent to the pharmacy, and the pharmacy comes back and says two things. This is not covered at all by your insurance, or this thing called prior authorization is required. And what we look at is how much that's happening over time. It's going up over time as people, I think, do have some general sense that this is happening more and more. And frequently, it's kind of split between both reasons, the drug not being covered at all, or the drug requiring prior authorization, or other types of utilization management, things that we sometimes call step therapies.
Prior authorization. Could you explain that real quick?
Your insurance company has a formulary where they have their list of things that they cover for you as one of their enrollees. And you can often, find these on the web. You can go look up your own formulary. And what that formulary says is how all of the drugs that exist are covered or not by your particular insurance plan. And one thing that it can happen with coverage is they might require additional information for your insurer to be willing to make the decision to pay for that prescription. So prior authorization means that the insurer has gotten approval from your physician and some specific information about you to ensure that is a medication that you actually need, that you're actually indicated for. Prior auth is kind of controversial. Some people think of it as this big administrative burden that is being placed on patients and physicians, that they're having to fill out this extra paperwork and jump through hoops to be able to get people prescriptions. But it does two things. It helps ensure, when used well, that patients are getting the correct medications for them. And we're not giving medicines that are maybe not needed, or we're not trying things that might be less cost-effective uses at the beginning.
So this isn't just my imagination. These things are becoming much more common. What surprised you most about the results?
We did something interesting. We weren't just looking at were the initial claims being paid or were they not being paid. We looked at what's happening afterwards. So we asked the question, if you are rejected because your drug is not covered by your insurance or because prior authorization is required, is that resolved? Are you able to overcome that barrier? And in the case of looking at all of our data together, it was true that after a rejection, only about half of those prescriptions eventually filled either the medication that was initially prescribed or what we define as a therapeutic alternative, a drug in a similar class to the drug that you got rejected for. So I think that was pretty notable to us that, 50% of the time, roughly, patients who had a new prescription were filling nothing within 90 days that would be considered a therapeutic alternative for the drug they got rejected for. And the trend is actually increasing over time. The percentage of people getting a new prescription, our data was looking from 2018 to 2024, this went up over that study period. And it's pretty unequally distributed between insurance types.
So break this down.
Why is this happening to people, and why aren't people getting their medication in the end? Is this administrative burden too much to overcome? Is it maybe a feature more than a bug?
So it's a mix of a lot of things, and it's a mix of things that we can't necessarily disentangle in this exact study. It certainly is this hoop that needs to be jumped through, in particular prior authorization, which is different than your insurance company not covering the drug at all. And we talk a lot about what is going on with those prior authorizations. How much are they simply a couple of check marks that your physician needs to fill out and send to the pharmacy to prove that you're actually indicated for this drug? And how much are they meant to actually reduce utilization, where they're creating so many hoops and there's all this time that needs to be spent filling them out and getting the correct information that people are just going to run away and abandon those drugs. I think both of those things are going on in this data, but we can't directly see it. So we're using the claims that we're getting from pharmacies to be able to identify this. On the other side of the coin, some of this probably is reasonable, that there are certain prescriptions that got written that it is not necessary, or it's not perhaps the clinically appropriate thing initially to try this drug first. So we don't have clinical information about the patients. This is administrative data coming from pharmacies to sort of say, oh, that was a good rejection versus not. So it's a mix. 50% we think is pretty notable. And the fact that it's gone up so much over time, even in the last 6 or 7 years, we're trying to contribute to discourse and understanding about how much prior auth burden there is that might help inform future quality policy questions, like how appropriate is it to use prior authorization for preventative medicines and certain types of other treatments that I think our data sheds a lot of light on.
Mm-hmm. So I've been hearing a lot about the GLP-1s, Ozempic, Wegovy, et cetera. Are these trends being mostly driven by those drugs, or is this happening across the board?
It's a great question, and it certainly is happening across many different classes of drugs. We actually kind of look specifically at that in this paper. It's happening in lots of types of drugs that you're seeing, advertisements for on television. Lots of diabetes drugs, lots of cardiovascular drugs, lots of rheumatoid arthritis drugs are very much in this data, but GLP-1s are the biggest rejected class in our data. In particular, the weight loss GLP-1s are in our data a lot, and they are being rejected at even higher rates than, the average that I said, which is about 68% are getting paid on average at the start. So it's a contributor to the growth, but it doesn't explain all the growth. We did sensitivity analysis where we removed the GLP-1s, and things are still increasing. But yes, GLP-1s, they're expensive. Insurers are concerned about how much they're spending on these drugs, and they are absolutely using utilization management, prior authorization, prove that you have these conditions or that you have a certain BMI to be able to get one of these drugs before we're willing to cover them. And outright exclusion, not being on the formularies, is actually pretty common for the weight loss indication GLP-1. So we know that that's going on, and we absolutely see that in our data.
Mm-hmm. So I imagine that insurance companies would say that these tools help keep drug costs down. So how should we think about the balance between controlling costs and making sure patients get the medications their doctors prescribe?
Yeah, it's a great question. And it's sort of the research question that we are trying to contribute to, because there's a lot of people concerned about prior auth. But prior auth helps keep drug costs down, and it potentially helps us better tailor treatments to individuals. And I'll say this has been a challenging thing to study. So health economists like me, we commonly use health insurance claims to study drug utilization and what treatments people are getting and what treatments they're not getting. And that has a big limitation in those are the things that insurance companies actually pay for. They're not the things that they don't pay for in those data sets frequently. So we actually acquired this data, which is different. It's not health insurance claims, it's claims coming from pharmacies. So it actually allows us to observe how frequently you're facing these burdens and you're getting rejected for all kinds of reasons, and then seeing what happens after. So I think your question is also my question. What is the appropriate amount of prior authorization? We get some positive things for society out of formularies being managed in certain ways. Another underappreciated aspect of formularies is they help insurance companies negotiate drug prices prices with drug manufacturers. And the ability to say to a drug manufacturer, hey, I'm going to prefer your product to your competitor's product on our formulary allows insurance companies to get better prices. And that's a challenging thing even to quantify because we're not privy to sort of the confidential amounts that are getting negotiated there. But the ability to set a formulary like that has positive impacts on spending. We spend less as a result of that. But you're absolutely right. The trade-off, how much abandoned prescriptions at the pharmacy and how much people going without medicine is worth that cost saving. So sort of in balance, that trade-off is very much what needs to be studied as policymakers are starting to address questions like, should we use prior authorization in Medicare? What does it mean to have formulary exclusion in Medicare? So I think I can't answer your question, but I'm hoping to answer your question with future research and access to more data like that.
Walk us through what happens. My doctor prescribes me a medication, and then I go to the pharmacy and they say, nope. So where in the process has everything gone sideways?
Right. And it's this very frustrating thing. Why did my doctor, write this prescription for me and send it to the pharmacy if it's not going to be covered? And to an extent, there's some technology software issues there where drug formularies are not consistent from health insurer to health insurer. So your clinician doesn't necessarily know exactly what is covered for you when they're deciding what treatment strategy to begin. So that's kind of this first step in the process is your clinician did something that it turns out your health insurance company is not going to pay for. You will learn that, though, often not at the clinician's office. You're learning it at the pharmacy, or often you might get a phone call from the pharmacy. Hey, you need to call your doctor and tell your doctor this isn't covered. Or your medication, you're going to pay the full price out of pocket. You're going to pay potentially thousands of dollars for one of these medications. We do think there are, some technology solutions to that burden problem, and embedding inside of electronic health records precise formulary information is the type of thing that there's software being developed to do that. But that's not equally available across all health systems and all physicians' offices. And we do think there's some geographic variation in how much access there is to those systems that are trying to help reduce this burden. You're asking what happens next. Your pharmacy has called you and told you you've now needed to call your physician's office, and they now need to go find a specific form that your insurance company requires to, prove that you need this medication. Sometimes they're very simple. Say, does this person have a diagnosis code for diabetes? If yes, we'll cover. Sometimes they can be much more onerous. Have they tried this other medication first? Have they tried this medication? Have they enrolled in a certain program about weight management in the case of some of these GLP-1s? So they really vary. And prior auth is not like one uniform thing. It can be very complex and, require some back and forth between the insurance company and the provider's office, or it can be much simpler. It can be a couple check marks. And it depends. And one thing that we see in our data is even these prior auth rejections that are then overcome, presumably by the prior auth process being completed, take often a week or 10 days to resolve and then eventually have a patient fill that prescription that their doctor was trying to get them.
I was going to ask about sort of where that fits in. People need treatment. Do people just give up, right? Like another call to the doctor, it was hard enough to get the first one answered, et cetera.
Right. And I think very much there's some, we said before, is there's some appropriate abandonment of these prescriptions going on. And then there certainly is some inappropriate abandonment of these prescriptions. The patient, I'm not going to deal with this administrative burden of having to call back and forth between different healthcare providers to ease this process. Was that the intent of the prior authorization policy? We hope not. We hope that's not exactly how insurance companies are choosing to set their formularies, to have X% of people abandoned, but I'm sure it is happening. And I sort of wish that I could tell you exactly how many people in our data that's why it happened. But I think this is very much the thing that needs to be studied, and us to really get a hold on allowing drug treatment to be sort of in this tiered formulary situation where you don't need to cover everything and you can have preferences and you can have barriers compared to, how much are people giving up and not getting treatments that they need. Because
I'm thinking also about a lot of medications are taken by elderly folks, and that They may not be as familiar with the system. They may be intimidated by the system. Some may be perhaps people who are economically disadvantaged. So I'm wondering what the end result of this becomes.
Yes, a couple things there, right? I mean, having access to more resources, you're going to be able to get others to work on your behalf to sort of overcome these barriers quicker and easier. But there's even sort of equity issues in the types of insurance coverage. So one thing we look at is the difference between Medicare and commercial insurance and Medicaid. And we do see for prior authorization and what we call utilization management barriers, they're highest, or they have the highest rates of rejection for prior auth Medicaid plans. But then sort of overall exchange plans, or what we think of as Affordable Care Act plans. And it's the design of those programs. And formularies are tighter. It's harder to get access to drugs in public insurance, in Medicaid. And also sort of these Affordable Care Act plans where people are not getting insurance through their employer. Now, we still see growth in all places. We see growth in rejections amongst commercially insured patients. We see some growth in Medicare, but overall, less rejections in Medicare compared to Medicaid, compared to commercial insurance. So it's distributed, across the whole country, across all insurance types, but it's distributed a little bit different.
So what are you going to look at next?
The hope is to take analysis like this and really tie it to clinical outcomes and ask the even more important question of, okay, these people abandoned the drugs. How did it impact their health? Did they have adverse events as a result of this? Did their hospitalizations rate go up? Does their cost of the rest of their care go up? And study the rejection as the starting point to see what happens next to people's health, because that is the point of these medicines, should be enriching people's health. And if we can show that these abandonments are really contributing negatively to people's health, I think that's important for policymakers to take note of.
Joe Levy, thanks so much for joining me.
Great. It was wonderful to be here. And thanks so much, Stephanie.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmon, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacobelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.